When everything bleeds, a surgeon's step-by-step crisis plan. There's a moment in surgery, and every experienced surgeon knows this moment, when the field turns red and the room goes quiet. The bleeding has started, and what you do in the next 30 seconds will define everything that follows. I want to talk to you about the scariest moment in an operating room. Not a difficult anatomy, not a complex reconstruction. I mean massive, unexpected bleeding. Even just for a second, completely lost. And I've been there. And today I'm going to give you the exact mental framework I use, the same one I teach every resident who scrubs with me. Welcome back. If you're new here, my name is Paul Del Prado. I'm a board certified general surgeon, and this channel is about thinking clearly in the OR, especially when things go wrong. Intraoperative hemorrhage is one of the leading causes of preventable surgical death, and the data is clear. The surgeons who manage it best aren't necessarily the most technically gifted. They're the most systematic. So let's build your system right now. So to build situational awareness, the first thing you have to ask is, when you're in the situation, suddenly you're doing an operation and you have a gush of blood and things start to go south. The first question you should ask is, where is the bleeding? Can you see it and control it? Your first two questions, and these need to fire automatically, and where is it and can I see it, are very important. Sounds obvious? But in the moment, panic compresses your thinking. You reach, you suture blindly, you pack without knowing what you're packing, and that's how small bleeds become catastrophic ones. Stop. Take a deep breath. Ask, where is the blood coming from? Is it venous, slow dark ooze? Is it from the field I'm working on, or has something nearby been injured? And critically, do you have the visualization and the instruments you need? If you can't see it, you can't control it. That is the rule. So your next job is to get exposure, and we'll come back exactly how. During this time, you have to make sure that there is closed loop communication with anesthesia. They have to be notified immediately, because the moment you have a significant bleed, open communication with anesthesia is of paramount importance. Right then. Not in 2 minutes, not after you've tried one thing. Say it clearly. We have significant bleeding. Is the patient stable? What's the BP? What's the map? And what are we working with? And occasionally when you're doing suction, you should ask how much is in the canister so that you have an estimate how much blood loss there is actively. Because here's reality. You and anesthesia are co-managing this patient. They need to know so they can start preparing additional IV access, pressors, blood products, a possible massive transfusion protocol. And if the patient is not stable, then your job shifts. You hold pressure and temporize, and this gives anesthesia time to catch up, because a brilliant repair on a patient who rests on the table means nothing. Patient stability is not their job. It's the whole team's job. Communication is how that happens. So once you have control and everybody is aware of what's happening, you have all the right access, they have blood products being transfused if needed, or they have it ready because you have an uncontrolled bleeding. Now you start working, how do I get exposure? Because you need to see, do you have the right exposure to identify the things? And that means retraction, an assist, and the things that you need to give you exposure, which includes your suction and the instruments to obtain hemostasis. So anesthesia is aware, pressure is held, patient is being stabilized. Now you set up to actually control this bleeding. And this setup is not optional. This is not the moment to rush. Rushing without a setup creates a second emergency. First, suction. Do you have good suction? Do you need two? Get two if you need to. Second, your assist. Is someone next to you? Do they know what you need? Are they the proper person in there? If you need more help, call another surgeon or move your assist to someone who has good experience. Third, how about the lighting? Can you actually see? Reposition the light so you're pointing towards what is the area of concern. And fourth, retraction, as we talked about. You cannot control what you cannot expose. Get the right retractors, the right angles, create the field you need, not only the one you have. So once you identify the source, you have to pick your weapon. Now and only now you identify the source precisely, and then you choose your control strategy based on what you're actually dealing with. Electric cautery for small venous bleeders, oozing surfaces, or small arterial bleeds. Suture ligation for anything significant. A named vessel, a pedicle you've entered, direct, reliable, and definitive. You have to choose whether you're ligating or you're repairing something if it's something major. You have to know what suture to use, what instruments that you need. If you need a vascular tray, you have to have it. Clips, when you have clear access and a discrete vessel. It's a fast and effective in the right situation, but you have to be able to circumferentially dissect the vessel and have it lifted so that you can place it under. For something more complex, you may consider pledgets and hemostatic agents, oxidized cellulose, gelatin matrix, fibrin sealants, when you're dealing with raw surface area ooze or parenchymal bleeding, or a bed you cannot directly suture. These are your friends in the liver, the spleen, and the retroperitoneum. And hemostatic packing, sometimes the right move is to pack, check the patient, and reassess. Damage control thinking. It's not failure, it's actually strategy. Finally, a drain to monitor if you believe you have control but aren't entirely certain. A low threshold for checking your work is a sign of wisdom, not weakness. Don't put a drain if you don't have good control because it will continue to bleed. So now let's move to the decision matrix. Do we continue? Do we temporize, or do we get out? And once you've controlled the bleeding, or you think you have, now comes the decision that separates experienced surgeons from inexperienced ones. What do you do next? You have three options. To continue the surgery if the patient is stable, bleeding is controlled, and the risk of completing the procedure is acceptable. To temporize, pack it, close temporarily, and get to the ICU, warm the patient, and correct coagulopathy. Bring them back in 24 to 48 hours when the physiology is better. This is damage control surgery, and it saves lives. 3. The operation is over. The patient needs resuscitation, not more surgery. You have to close and move and recover, because sometimes this may be more detrimental to the patient if you continue to proceed and then they continue to bleed or become coagulopathic. The instinct to finish what you started is powerful. Do not let it kill your patient. The decision to temporize or abort is not a failure of skill. It is the highest form of surgical judgment. Let me leave you with this. The surgeons I have most respected over the course of my career, the ones I would want operating on someone I love, are not the ones who never had a major bleed. They're the ones who had a plan when it happened. And now you do too. Localize it, communicate clearly, hold pressure while the team catches up, set it up deliberately, control it with the right tools, make the right decision for your patient, not your ego. If this was useful, subscribe. I put out a new video every week on surgical decision making, case breakdowns, and stuff they don't fully teach in residency. Drop in the comments what's the most difficult intraoperative bleeding situation you've faced or seen. I read every single one, and I'll see you guys next time.